Welcome, everyone, to today's deep dive.
And we've got a really intense one lined up for you today.
We absolutely do. And when I say everyone, I am talking directly to you.
Yep, the nursing student.
Exactly. Whether you are, prepping for a brutal clinical rotation.
Or staring down a massive patho exam.
Right, the kind that keeps you up at night. Or maybe you're gearing up for the NCLEX.
You are definitely in the perfect place.
Today's mission is critical. And honestly, it's a little intimidating.
Heavy stuff.
We are going to master the high-stakes complexities of congestive heart failure.
CHF.
CHF, right. And then we're going to push straight into the adrenaline-pumping territory of ACLS.
Advanced cardiovascular life support.
But we are absolutely not going to do this by reading off a sterile list of symptoms.
No flashcards today.
No flashcards. We have a massive stack of incredibly detailed source materials, clinical guidelines, and slides.
And we're synthesizing all of it by throwing you right into the fire.
We are putting you right at the bedside of an actively crashing patient.
Because that bedside context, that's where textbook theory either crystallizes into clinical judgment or it just completely falls apart.
Yeah, you have to apply it.
Exactly. For a nursing student, the magic happens when you stop memorizing isolated facts.
Right.
And you start looking at a living, breathing patient. You look at their specific numbers, and you instantly translate the distress signal their body is sending.
Because in acute care, missing that signal.
A manageable situation turns into a code blue very, very quickly.
So let's step into that patient's room right now.
Let's do it.
I want to paint the picture of this complex scenario, and this is sourced directly from our clinical materials.
Pay close attention to the timelines here.
Yes. Imagine it is Aero 900. Your patient is reporting difficulty breathing.
Dyspnea.
Right. And a significant, really unusual decrease in their energy levels.
So they're exhausted.
Completely wiped out. You start your initial head-to-toe assessment, looking at their lower extremities. You observe 2+ pitting edema bilaterally.
So you press your thumb in, and that indentation just stays there.
It just stays. Then you put your stethoscope to their back, you ask them to take a deep breath, and crackles are clearly audible in the bilateral lung bases.
That wet popping sound.
Exactly. The patient also mentions they simply haven't had an appetite. Decreased oral intake over the last 24 hours.
Okay, so let's look at the numbers. What are the vitals?
Vitals at 0900. Temperature is 36.5 degrees Celsius.
Normal.
Heart rate is 108.
Tachycardic.
Respiratory rate is 22.
Slightly touching neck.
Blood pressure is 145/90.
Elevated.
And the oxygen saturation is sitting at 91% on room air.
Okay, those initial findings, they should absolutely make you pause.
Right, the body's working way harder than it should have to.
The tachycardia, the borderline oxygen, but the lab values add a really crucial layer to this.
Yeah, the 0900 labs come back and they are eye-opening.
Let's hear them.
BUN is 30.
Haha.
Creatinine is 1.8.
Also high.
BNP is sitting at 900.
Wow, okay.
And potassium is 5.2.
Slightly elevated.
So that is your 0900 baseline. You document, you implement your basic nursing care, and you monitor.
But things change.
They change fast. Let's fast forward just 3 hours. It is now 1200.
You walk back into the room.
You walk in, and the patient's condition has fundamentally shifted.
You can just feel it.
You touch their arm, and their skin is now cool to the touch.
Or perfusion.
You pull back the blanket, and that pedal edema has noticeably increased in just 3 hours.
The fluid is shifting rapidly.
When you try to reposition them, they require significantly more assistance just to turn in bed. Their weakness is profound.
So you grab a new set of vitals immediately.
Immediately. Temperature is still 36.5, but the heart rate has climbed to 115.
It's getting faster.
Respiratory rate is up to 24.
Breathing harder.
Blood pressure has ticked up to 150/95. And the glaring red flag.
The oxygen.
That oxygen saturation is actively dropping. It is now sitting at 88% on room air.
The patient is slipping.
Yeah.
Whatever compensatory mechanisms they were using at 0900, they're completely failing by 1200.
So you page the provider, they assess the situation, and put in a set of stat orders.
Action time.
As the primary nurse, here is what you are tasked to do. Administer furosemide 40 milligrams AV once, right now.
And monitor urine output.
Yes. Begin supplemental oxygen therapy at 2 liters via nasal cannula.
Standard.
And restrict oral fluid intake to 1,500 milliliters for the next 24 hours.
Okay.
Which brings us to our ultimate NCLEX-style challenge for this deep dive.
This is where we test you.
Based on this rapid clinical deterioration, you need to determine the priority nursing interventions for this client across 4 distinct body systems.
Respiratory, cardiovascular, urinary, and digestive.
You need to know exactly what to do, what to avoid at all costs, and the physiological why behind every single choice.
But before we reveal the answers,
Okay, let's unpack this. We are going to intentionally pause the scenario right here.
golden pause.
Yes, we have to dive into a deep clinical analysis of what is actually happening inside this human being's chest before we touch a single vial of medication.
I love that you call it that. Real-life nursing isn't about blindly executing a checklist of provider orders.
No, it's about anticipation.
It's about anticipating the trajectory of the disease. So let's guide you through that critical thinking framework. First, what is the core problem here?
Looking at the shift from 0900 to 1200, this patient is in the throes of an acute exacerbation of heart failure.
They are experiencing severe fluid overload.
Right, and because that fluid is trapped in the wrong compartments, they are suffering from poor systemic tissue perfusion.
Which perfectly explains the skin assessment.
Exactly. At 0900, it wasn't noted as abnormal, but by 1200, the skin is cool to the touch.
The heart isn't pushing warm oxygenated blood to the periphery.
The body is literally shunting blood away from the skin to protect the brain and the vital organs.
It's in survival mode. But when we prioritize as nurses, we always fall back on the ABCs.
Airway, breathing, circulation.
Followed by safety and psychosocial. So where does this specific 1200 crisis land on that matrix?
It lands squarely as a combined breathing and circulation crisis.
They are completely entangled here.
The heart, representing circulation, is failing as a mechanical pump.
And because it cannot push blood forward effectively, that blood physically backs up. It has to go somewhere.
Basic plumbing.
Right. And the immediate off-ramp for blood backing up from the left side of the heart is the pulmonary circulation.
The lungs.
The lungs. That fluid accumulation physically floods the alveolar spaces.
Which severely compromises gas exchange. That's the breathing component.
That mechanical failure is why the oxygen saturations have dropped from a marginal 91% down to a terrifying 88%.
And it is why those crackles are audible. The patient is quite literally drowning in their own fluid.
That is a stark, terrifying reality for the patient.
If the nurse hesitates here, what is the most immediate life-threatening risk?
The immediate risk is a complete plunge into acute pulmonary edema, culminating in severe respiratory failure.
The lungs just become waterlogged.
So waterlogged that no oxygen can transfer into the bloodstream. And furthermore, look at that heart rate climbing to 115.
The heart is desperately trying to compensate.
It's trying to make up for a weak stroke volume by beating faster. If that cardiac output continues to plummet, the patient enters cardiogenic shock.
That's a state where the pump fails so profoundly that the body's organs actually begin to suffer ischemic death from lack of oxygen.
So the intervention that breaks this cycle, the thing that prevents deterioration, has to be the immediate offloading of that trapped fluid.
And drastically improving oxygenation.
We have to execute those provider orders flawlessly.
Getting that 5-E furosemide in to force the kidneys to dump the fluid.
Applying the supplemental oxygen to saturate whatever healthy alveoli are left.
And ensuring optimal physical positioning to facilitate lung expansion.
If we connect this to the bigger picture, to understand why those specific interventions will save this patient's life, and why other actions could actually kill them, we have to look under the hood.
We really do. We have to examine the pathophysiology of the failing heart.
Let's break down those mechanics.
The sources define heart failure as a clinical syndrome resulting from structural or functional cardiac disorders.
Meaning the heart is unable to pump enough blood to meet the body's metabolic demands.
It feels like a massive supply and demand mismatch.
The body is screaming for oxygen, and the delivery system is just broken.
But the slides make a very clear distinction between 2 types of dysfunction.
Systolic and diastolic.
I hear those terms constantly, but they often blur together for students. What is the actual mechanical difference happening inside the muscle?
Okay, think of the heart as a mechanical pump that goes through 2 distinct phases. A squeezing phase and a relaxing phase.
Right.
Systolic dysfunction is a problem with the squeeze.
The contraction.
Exactly. The heart muscle has become weak, thin, and flabby. This often happens after a massive myocardial infarction, a heart attack.
Where a portion of the muscle tissue literally dies.
It dies and is replaced by non-contractile scar tissue. It can't squeeze anymore. So when the left ventricle tries to contract and eject blood out into the aorta, it just gives this weak, ineffective push.
And that's where the ejection fraction comes in.
The percentage of blood the ventricle manages to pump out. With each beat, drops severely.
So the pump is too weak to push the fluid out. What about diastolic dysfunction?
Diastolic dysfunction is entirely different. It is not a pumping problem.
It's a filling problem.
Yes. Imagine a normal heart, like a soft, highly pliable kitchen sponge. You squeeze it, the water empties.
Yeah.
You let go, and it immediately springs back to its full size, completely soaking up new water.
It fills easily.
But now, imagine a sponge that has been left out in the sun to dry.
Oh, stiff. Rigid.
Stiff, thick, and rigid.
Yeah.
This happens to the heart muscle after years of fighting against uncontrolled hypertension.
High blood pressure.
The heart has to build up massive, thick muscle walls just to push against that high pressure. Because the muscle is so thick and stiff, when it tries to relax during diastole, it cannot fully expand.
A sponge only fills up halfway.
Exactly. Even if that ventricle squeezes with incredible force, it doesn't matter because it didn't fill with enough blood in the first place.
But the end result is exactly the same, right? A critical drop in cardiac output.
Yes, the forward flow drops regardless.
Now, our patient at 1200 is clearly having an acute crisis. But how does this differ from the chronic heart failure we see in patients managing this for years at home?
Chronic heart failure is a slow, progressive burn. The body has time to deploy compensatory mechanisms.
Patients can live with it for decades.
With a delicate, highly regimented balance of daily weights, strict sodium limits, and a complex cocktail of oral medications.
But acute heart failure, which our patient is experiencing, is a sudden, terrifying decompensation.
It features a rapid onset of obvious fluid buildup, a sudden crash in tissue perfusion, and it is an absolute medical emergency requiring immediate hospitalization and IV interventions.
What actually pushes a stable chronic patient over the edge into an acute exacerbation?
There are several classic triggers. A new heart attack can instantly knock out a critical percentage of the remaining functional muscle.
Obviously.
Arrhythmias are a massive culprit, particularly atrial fibrillation. In AFib, the upper chambers of the heart, the atria, stop delivering a coordinated squeeze and instead just quiver like a bag of worms.
You instantly lose the atrial kick that tops off the ventricles.
Exactly, drastically dropping cardiac output. Severe infections like pneumonia are another trigger.
Because an infection revs up the body's metabolism.
It demands a huge increase in blood flow that the failing heart simply cannot provide. But practically speaking, one of the most common triggers you will see at the bedside is dietary or medical non-adherence.
Let me guess, the classic holiday weekend admission.
Exactly that. The patient goes to a summer barbecue, eats a hot dog loaded with hidden sodium, perhaps forgets their morning diuretic pill.
And 3 days later, they are sitting in your emergency department in severe respiratory distress.
Which brings us back to our specific 0900 and 1200 presentation. We have to separate left-sided from right-sided heart failure.
Because our patient is flashing warning signs for both. Let's start with the left side.
The left ventricle is the heavy lifter.
It takes oxygenated blood from the lungs and pumps it out through the aorta to the entire systemic circulation.
So if the left side is failing, it can't push that blood forward.
What happens physically when that blood backs up?
It's basic plumbing again. If the drain is clogged, the water backs up into the pipe behind it.
And the structures immediately behind the left side of the heart are the pulmonary veins and the lungs.
This creates intense pulmonary congestion. The blood backs up, increasing the hydrostatic pressure inside those tiny, delicate pulmonary capillaries.
The pressure gets so high that the fluid component of the blood is physically forced through the capillary walls.
And into the alveolar spaces. The air sacs fill with water.
That perfectly translates to the symptoms. Dyspnea, or shortness of breath because the lungs are heavy and wet.
Orthopnea.
Which is severe shortness of breath when lying flat.
When a patient lies flat, gravity allows that trapped fluid to spread out evenly across the entire surface area of the lungs.
Drowning more alveoli.
Then there is paroxysmal nocturnal dyspnea, or PND,
where a patient wakes up in a sheer panic 2 hours after falling asleep, gasping for air.
You might see a cough that starts dry, but turns into a terrifying pink, frothy sputum.
That happens if the capillary pressure gets so high that red blood cells start bursting into the airway.
And of course you hear crackles.
Which is the sound of air trying to violently pop open those fluid-filled air sacs.
Now tie that directly to our patient. At 0900, they complained of difficulty breathing. You heard bilateral crackles. Their oxygen dropped from 91% down to 88% by 1200.
This is the undeniable textbook presentation of left-sided heart failure causing acute pulmonary edema.
But the clinical picture doesn't stop at the lungs. We also have right-sided heart failure.
The right ventricle has a different job. It receives deoxygenated blood from the body and pumps it into the lungs to be oxygenated.
If the right ventricle fails, it can't push blood into the pulmonary circulation. So where does that traffic jam end up?
It backs up into the systemic venous system.
The blood pools in the superior and inferior vena cava.
When it backs up into the superior vena cava, it engorges the vessels in the neck.
Causing jugular venous distension, or JVD. You can visibly see the veins bulging.
When it backs up into the inferior vena cava, the consequences are even more widespread.
It engorges the liver, leading to hepatomegaly. The increased pressure in the portal vein forces fluid to leak into the peritoneal cavity of the abdomen,
Causing ascites, massive, uncomfortable abdominal swelling.
This leads to profound nausea and a complete loss of appetite, anorexia,
Finally, because of gravity, the backed-up fluid sinks to the lowest points of the body.
causing dependent edema. You see massive swelling in the feet, ankles, and calves, or in the sacral area if the patient is bedbound.
Again, look at our patient. At 0900, they had 2+ pitting edema in the lower extremities. By 1200, that pedal edema was worsening,
They reported a decreased oral intake over the last 24 hours.
which points to that gut engorgement. And the extreme weakness and decreased energy round out the picture. Our patient is clearly exhibiting signs of both right and left-sided failure simultaneously.
That combined presentation is actually the norm. In fact, the single most common cause of right-sided heart failure is left-sided heart failure.
Because when the left side fails, pressure builds up massively in the lungs.
The right ventricle then has to pump against that incredibly high pulmonary resistance.
And the right ventricle is thin-walled. It wasn't designed for high-pressure pumping.
Eventually, it just burns out from the effort, creating a devastating system-wide domino effect.
That transition from physical assessment directly into the pathophysiology is fascinating. But as a nurse, you are also relying heavily on objective data.
The numbers.
Let's decode the diagnostics in the labs. We have these very specific numbers from 0900 and 1200. I want to start with the heavy hitter,
BNP.
brain natriuretic peptide. Our patient's BNP was 900 at 0900, and it crept up to 900 by 1200. Normal is generally considered less than 100. What exactly is this molecule, and why is it soaring?
Despite the confusing name brain natriuretic peptide, because it was originally discovered in porcine brains, it is actually secreted primarily by the ventricular cells of the heart.
Think of BNP as a biological distress flare.
When the heart is overloaded with massive amounts of fluid, the ventricular walls physically stretch, like a water balloon being filled to its absolute breaking point.
In response to that severe stretching, the heart cells synthesize and release BNP into the bloodstream.
It is an objective, undeniable biomarker of stretch and volume overload.
So a level of 900 climbing to 920 isn't just a minor elevation.
No, it is the heart screaming that it is being torn apart by volume. It confirms that the fluid accumulation is actively worsening between our two assessments.
Now, what about the BUN and creatinine? At 0900, the BUN was 30 and creatinine was 1.8. By 1200, they climbed to 32 and 1.9.
Normal BUN is roughly 7 to 20, and normal creatinine is around 0.6 to 1.2. They are elevated.
But why are we intensely focused on kidney labs when the primary failure is in the chest?
Because of the cardiorenal connection. This is perhaps one of the most critical concepts for a nursing student to grasp.
Heart failure is essentially a devastating miscommunication between the heart and the kidneys.
The kidneys are incredibly greedy organs. They demand an enormous constant flow of cardiac output to filter toxins effectively.
When the heart fails, cardiac output drops. The body shunts blood away from the kidneys to prioritize the brain.
So the kidneys are starving for blood, they become hypoperfused.
Yes, and because they aren't getting blood flow, they cannot filter out waste products.
Which is why the BUN and creatinine begin to pile up in the bloodstream.
But the tragedy is how the kidneys react to this starvation.
The kidneys don't know the heart is failing. They just sense the low blood pressure and assume the body must be bleeding out in a desert somewhere.
They act like a panic building manager who smells smoke, assumes there's a massive fire, and turns on all the sprinkler systems.
They activate the renin-angiotensin-aldosterone system,
Yeah.
or RAAS.
To aggressively hold on to every drop of sodium and water they can find, trying to boost the blood volume.
Which is the absolute worst thing that could possibly happen. The heart is already drowning in fluid, and the kidneys are frantically pumping more water into this sinking ship.
It is a lethal feedback loop. That is why monitoring kidney function is paramount. The kidneys are actively making the heart failure worse.
Finally, we have to look at potassium. The patient's potassium is slightly elevated at 5.2, moving to 5.4. Normal is roughly 3.5 to 5.0.
Potassium is the master regulator of the heart's electrical stability. If it swings too high or too low, you risk immediate fatal arrhythmias.
A level of 5.4 is likely related to the poor kidney function. The kidneys are failing to excrete the potassium.
But as the nurse, knowing this baseline is vital because of the 1200 orders, the provider ordered furosemide,
A massive loop diuretic.
which will aggressively wash potassium out of the body. You have to know where the potassium is starting so you can anticipate the drop.
Beyond the blood work, the diagnostic picture relies heavily on imaging. The echocardiogram is the cornerstone.
It is an ultrasound that allows us to visualize the valves, assess the wall thickness, and definitively calculate that ejection fraction.
To distinguish between systolic and diastolic failure.
Chest x-rays will visually confirm the pulmonary congestion and show an enlarged cardiac silhouette.
While 12-lead ECGs hunt for arrhythmias or silent ischemic events that might have triggered the acute crisis.
The sources also outline classification systems to standardize how the medical team communicates the severity of the disease. There is the ACCAH system,
Which uses stages A, B, C, and D. It focuses heavily on the structural progression.
Stage A is just having risk factors like hypertension with no structural damage.
Stage C means you have structural damage and symptoms. The key here is that it's a one-way street. Once you reach stage C, you can never go back to stage B, even if you feel better.
Conversely, the NYHA classification system.
Using classes I through 5E.
It focuses purely on the patient's subjective symptoms and physical limitations. Class I means no limitations.
Class 4 means severe symptoms even while sitting perfectly still at rest.
Unlike the structural stages, NYHA classes can fluctuate. A patient might come into the ER as a Class 4, drowning in fluid, but after aggressive IV diuresis, they might be discharged as a Class 2.
Able to walk around their house with only mild shortness of breath.
So we know the heart is drowning. We know the kidneys are actively sabotaging the recovery. And we know the classifications. How do we actually intervene?
The pharmacological arsenal for heart failure is massive.
The overarching strategy is called Guideline-Directed Medical Therapy, or GDMT.
The goals are to improve cardiac function, obliterate the symptoms, lower readmission rates, and actually extend the patient's life.
The provider ordered 40 milligrams of 5E furosemide right now. Walk me through the mechanics of this intervention.
In an acute, decompensated crisis like our 1200 scenario, loop diuretics are the absolute first-line heavy hitters.
Furosemide, bumetanide, torsemide.
They act directly on the ascending limb of the loop of Henle inside the kidneys. Their job is to aggressively block the reabsorption of sodium and chloride back into the bloodstream.
And the golden rule of fluid dynamics in the body is, where sodium goes, water follows.
Precisely. By trapping the sodium inside the kidney tubules, the furosemide forces massive amounts of excess extracellular water to stay in the tubules.
And be excreted as urine. It rapidly depletes the blood volume.
This directly decreases the venous return to the heart, which lowers the pulmonary capillary hydrostatic pressure, which stops the fluid from leaking into the lungs.
It literally pulls the water out of the alveoli, allowing the patient to breathe again.
Pushing furosemide is a major nursing responsibility. You don't just slam it into the IV and walk away.
What are the specific bedside priorities?
You must check the baseline blood pressure. If the patient is severely hypotensive, rapidly dropping their blood volume with a diuretic will crash their pressure completely.
You must check their potassium, as we discussed, because loop diuretics cause severe potassium wasting.
You must monitor their BUN and creatinine, because pulling volume too fast can further starve the already hypoperfused kidneys.
And after you push the drug, the nursing interventions intensify. You must implement strict intake and output tracking.
Every single milliliter of urine must be measured to gauge the drug's efficacy.
And daily weights, right?
Yeah.
The slides emphasize this.
Daily weights are the undisputed gold standard for tracking fluid status.
INOs are notoriously inaccurate due to insensible losses, spilled urinals, or sweating.
But a scale does not lie. Weighing the patient at the exact same time every morning on the exact same scale, wearing the exact same amount of clothing, gives you a perfect objective measurement.
1 kilogram of weight loss equals exactly 1 liter of fluid removed.
While diuretics manage the immediate flood, they don't fix the underlying disease process. Let's look at the drugs that actually alter the trajectory of heart failure.
SGLT2 inhibitors like dapagliflozin and empagliflozin.
These are fascinating because they were originally designed solely for diabetes management, to force the kidneys to excrete excess blood sugar.
How did they become a miracle drug for heart failure?
It was an incredible secondary discovery. Cardiologists noticed that diabetic patients taking SGLT2 inhibitors were having drastically fewer heart failure exacerbations.
These drugs promote osmotic diuresis, pulling fluid out alongside the glucose, which reduces preload.
But they also improve the actual metabolic efficiency of the heart muscle cells and reduce arterial stiffness, lowering afterload.
For the nurse, the key monitoring points are watching the kidney function, monitoring for hypotension, and, critically, assessing for urinary tract infections or severe genital mycotic infections.
Because you were essentially creating a high-sugar environment in the urinary tract that bacteria and yeast love.
Next, we have to tackle the drugs that shut down that panicked building manager, the RAAS system.
A renin-angiotensin system blockers.
This includes ACE inhibitors like lisinopril, ARBs like valsartan, and ARNIs like sacubitril/valsartan.
And when the kidneys release renin, it eventually converts to angiotensin II, which is one of the most potent vasoconstrictors in the human body.
It clamps down the blood vessels to raise blood pressure. It also triggers the release of aldosterone, which hoards sodium and water.
These medications sever that devastating feedback loop. ACE inhibitors block the conversion to angiotensin II.
ARBs block the receptors where angiotensin II tries to attach.
By stopping this system, the blood vessels dilate, immediately reducing the resistance the heart has to pump against the afterload.
It also stops the sodium and water hoarding. Over time, these drugs actually prevent the physical remodeling of the heart muscle, stopping it from getting stiffer and weaker.
What is the nurse looking for at the bedside with these RAS blockers?
Profound hypotension is a major risk, especially after the first dose.
Because these drugs block aldosterone, which normally tells the body to excrete potassium in exchange for sodium, they cause the body to hold on to potassium. So hyperkalemia is a significant danger.
For ACE inhibitors specifically, you must assess for a persistent, dry, hacking cough.
This happens because ACE inhibitors also block the breakdown of bradykinin, an inflammatory mediator that builds up in the lungs and irritates the airways.
If the cough is intolerable, the provider will usually switch them to an ARB. And, as always, keep a hawk's eye on the BUN and creatinine.
Now let's talk about beta blockers. Bisoprolol, carvedilol, metoprolol.
For decades, the dogma was that you never give a beta blocker to a heart failure patient. Beta blockers are negative inotropes. They decrease the force of the heart's contraction.
If the pump is already failing, why on earth would we want to weaken its squeeze?
It seems counterintuitive, but the modern understanding of the sympathetic nervous system changed everything.
When cardiac output drops, the body panics and floods the system with adrenaline and noradrenaline. It activates the fight-or-flight response, constantly whipping the heart to beat faster and harder.
Imagine a horse that is starving, exhausted, and pulling a heavy cart. The sympathetic nervous system is the rider whipping the horse relentlessly.
It might go faster for a few miles, but eventually the horse will drop dead from exhaustion.
The beta blocker takes away the whip.
Exactly. Beta blockers shield the fragile heart muscle from the toxic, continuous bombardment of adrenaline. They slow the heart rate down.
This slower rate is crucial because it allows the ventricles more time to actually fill with blood during the relaxation phase, diastole.
By lowering the workload and oxygen demand, beta blockers actually allow the heart muscle to heal and reverse some of the structural damage over months and years.
But timing is everything. Look at our patient at 1200, tachycardic at 115, actively decompensating, dropping oxygen. Do we push a beta blocker right now?
Absolutely not. In an acute, wet, decompensated crisis, taking away that sympathetic drive can cause the remaining cardiac output to crash entirely.
You hold the beta blockers until the patient is diuresed, dry, and hemodynamically stable.
When you do initiate them, the nurse must monitor for profound bradycardia, hypotension, and warn the patient that they might feel increased fatigue for the first few weeks as their body adjusts to the lack of adrenaline.
The final major class mentioned is hydralazine isorbidenitrate.
This is a powerful combination of direct vasodilators. It forces the blood vessels to relax, drastically decreasing both the volume returning to the heart and the resistance it must pump against.
It is particularly effective in African American populations who remain symptomatic despite optimal therapy with other classes. The primary nursing assessment here is monitoring for severe headache-inducing hypotension.
The pharmacology is intricate, but we have to remember that a provider can write the most brilliant, perfectly optimized GDMT prescription in the world, and if the nursing process fails, the patient will be readmitted within a week.
The nursing care is what binds this all together. Here's where it gets really interesting.
Let's start with nutrition, specifically sodium restriction.
The general guideline is limiting intake to less than 2 grams per day. We know that sodium acts like a sponge in the vasculature. It holds onto water, expanding the blood volume, which stretches the failing heart further.
But teaching this is incredibly hard.
It is deeply challenging because the danger isn't the salt shaker on the dining table.
The danger is the hidden sodium in modern diets. Canned soups, processed deli meats, frozen dinners, and restaurant foods are absolute sodium bombs.
A single serving of canned soup can contain more than the entire 2-gram daily allowance.
The nurse has to sit down, look at the patient's actual diet, and teach them how to read a nutrition label, focusing on the milligrams of sodium per serving, not just the word low salt on the front of the box.
Now, here is a fascinating paradox from the slides. Historically, every single heart failure patient was put on a miserable, strict fluid restriction.
But the latest evidence suggests that for chronic, stable outpatients, strict fluid restriction doesn't actually improve outcomes. It just causes terrible thirst and diminishes quality of life.
But look at our specific patient orders at 1200. The provider ordered a strict oral fluid restriction of 1500 milliliter for the next 24 hours. Why the contradiction?
This highlights the difference between chronic management and acute crisis intervention. A stable outpatient doesn't need to torture themselves with fluid limits as long as they are avoiding sodium and taking their diuretics.
However, our patient is actively drowning. They are in an acute decompensated state, their O2 is dropping, and they have severe pitting edema.
While we are aggressively using IV furosemide to pull fluid out, we absolutely must stop them from pouring new fluid back in. In this acute phase, the individualized provider order always supersedes general chronic guidelines.
Beyond intake, what physical interventions does the nurse perform at the bedside? We need to talk about activity tolerance.
The old textbook answer was to prescribe strict, prolonged bed rest to decrease the heart's workload.
We now know that strict bed rest is highly detrimental. It leads to rapid muscle wasting, severe deconditioning, and drastically increases the risk of deep vein thrombosis.
The modern nursing goal is to develop a highly structured schedule that alternates periods of light, progressive physical activity with mandatory periods of rest.
You watch the patient closely. If they walk to the bathroom and their heart rate skyrockets by 30 beats, or their oxygen drops, or they become dizzy, you stop the activity immediately. You pace their recovery.
We also have to physically manage the fluid volume through positioning. When I walk into that 1200 scenario, the very first physical thing I am doing before the meds even arrive is raising the head of the bed.
High Fowler's position. This is basic physics applied to human anatomy.
If you lay a heart failure patient flat, all the fluid trapped in their legs and abdomen rushes back into the central circulation, overwhelming the right ventricle and flooding the lungs instantly.
By sitting them upright at 90 degrees, gravity pulls the fluid down toward the lung bases, physically freeing up the upper alveolar fields for gas exchange.
It also drops the diaphragm, allowing the lungs to expand more fully.
We cannot ignore the psychosocial terror of this disease. Imagine the sensation of air hunger. It is one of the most primal, terrifying feelings a human can experience.
That panic triggers a massive adrenaline release, which whips the failing heart harder, which increases the oxygen demand, which worsens the failure. It is a deadly, self-perpetuating spiral.
The nurse is the only one who can break that psychological spiral. You do not leave a patient who's struggling to breathe alone.
You stay in the room. You project a calm, deliberate competence. You talk them through pursed lip breathing techniques.
You educate them on what the furosemide is going to do, explaining that relief is coming. By involving them in the process, you strip away the feeling of utter powerlessness.
You also must actively screen for clinical depression. The rates of depression in chronic heart failure are staggering, and a depressed patient is far less likely to adhere to their complex medication and diet regimen,
leading directly to readmission. As the acute crisis resolves and we prepare for discharge, the education piece becomes paramount. The slides emphasize the teach-back method.
You don't just hand them a pamphlet on daily weights. You say, "Mr. Smith, I want to make sure I explain this clearly. Can you tell me exactly how and when you're going to weigh yourself tomorrow morning?"
If they say, "After breakfast, whenever I get around to it," you know your education failed and you have to start over.
Transitioning them to specialized heart failure clinics or setting up telehealth monitoring for their daily weights at home is crucial.
And as difficult as it is, the nurse must also navigate the reality that chronic heart failure is ultimately a progressive terminal disease.
Advanced care planning, discussing advanced directives, and knowing when to transition the focus from curative treatment to palliative or hospice care is a profound nursing responsibility.
Ensuring the patient's final stages are managed with dignity, free from the terror of air hunger, is just as important as managing an acute crisis.
That is a heavy, necessary truth. But this raises an important question. What if we are too late? What if the interventions fail, or the patient simply crashes before the furosemide can work?
We have to look at the dark side of this condition, when the bottom drops out entirely.
We must walk through these critical complications so that when you see them at the bedside, you recognize them instantly, because you will only have minutes to react.
They've touched on the most immediate threat, acute pulmonary edema. This is the cliff our 1,200 patient is dangling over.
The left ventricle has failed completely, the pulmonary capillary pressure has exploded, and fluid is violently filling the lungs.
The patient will be in severe, visible respiratory distress, using all accessory muscles to breathe. Their oxygen saturation will plummet.
And the hallmark sign, the absolute red alert, is coughing up pink, frothy sputum.
This means the pressure has literally ruptured the delicate capillary walls, and red blood cells are mixing with the fluid and air in the alveoli to create a bloody foam.
The interventions must be aggressive and immediate. You slam the IV diuretics, you administer potent vasodilators like nitroglycerin to massively expand the venous system and pull blood away from the lungs.
You aggressively escalate oxygen therapy. A simple nasal cannula will not work. You need high-flow oxygen, often progressing rapidly to positive pressure ventilation like CPAP or BiPAP.
To physically force the fluid back across the alveolar membrane, or even full endotracheal intubation and mechanical ventilation to save their life.
What happens if the pump fails so completely that the entire cardiovascular system loses pressure?
That is cardiogenic shock. It is the ultimate failure of perfusion. The cardiac output drops so low that it cannot sustain basic cellular life.
The blood pressure tanks dramatically. The heart rate skyrockets in a futile attempt to compensate.
Because the kidneys are getting zero blood flow, urine output stops entirely en ria.
The brain is starved of oxygen, so the patient's mentation declines from confusion to lethargy to coma.
It has a devastatingly high mortality rate. It requires immediate transfer to the ICU, continuous infusions of potent vasoactive medications to artificially maintain blood pressure, and often mechanical circulatory support.
Like an intra-aortic balloon pump or an LVAD to manually pump the blood. Another insidious complication is thromboembolism. Blood clots. Heart failure patients are a massive setup for clot formation. Why?
It comes down to Virchow's triad, specifically venous stasis. Blood is meant to move. When it sits still, it clots.
First, many of these patients have atrial fibrillation.
The atria are quivering, not squeezing, so blood pools in the little appendages of the atria and forms massive clots.
Second, the left ventricle is so weak that it leaves a pool of stagnant blood behind after every weak contraction, allowing mural thrombi to form on the ventricular walls.
Third, the severe peripheral edema and lack of physical mobility allow blood to pool in the deep veins of the legs, forming deep vein thrombosis or DVTs.
And the terror of clots is that they travel. If a clot breaks loose from the left side of the heart, it is pumped out into the aorta. Its favorite path is straight up the carotid arteries into the brain, causing a massive, devastating ischemic stroke.
If a DVT breaks loose from the leg, it travels up the inferior vena cava, through the right side of the heart, and slams directly into the pulmonary artery.
This is a pulmonary embolism, or PE. It instantly cuts off blood flow to the lungs, causing acute right-sided heart failure and sudden death.
This is why echocardiograms are essential to hunt for these hidden clots, and why patients are heavily managed on anticoagulants.
There is also a severe mechanical complication we must discuss: pericardial effusion leading to cardiac tamponade.
The heart doesn't just hang freely in the chest. It sits inside a tough, fibrous protective sac called the pericardium.
Normally, there's just a few milliliters of lubricating fluid between the heart and this sac, but an effusion is the abnormal, massive accumulation of fluid inside that sac.
It could be triggered by advanced heart failure, viral pericarditis, chest trauma, or metastatic cancer.
The anatomy here is the problem. The pericardial sac is tough and fibrous. It does not stretch easily.
So, as fluid rapidly fills that confined space, it has nowhere to expand outward. Instead, it pushes inward, physically crushing the heart chamber.
Because the atria and right ventricle have thin walls and low pressure, they are the first to collapse. If the heart is being crushed from the outside, it cannot distend and fill with blood during diastole.
If it can't fill, It can't pump. When this fluid accumulation becomes hemodynamically significant, it is called cardiac tamponade.
Acute cardiac tamponade is a code-level emergency. The clinical manifestations are striking. The patient will complain of sudden severe chest pain and extreme shortness of breath.
When you look at them, you will see a classic presentation known as Beck's triad.
First, you will see profound, massive jugular venous distension because the right atrium is collapsed and cannot accept any returning blood.
Second, you will see profound hypotension because the left ventricle cannot fill, so cardiac output plummets.
Third, when you put your stethoscope to their chest, you will hear muffled, distant heart sounds because you are trying to listen through a thick, dense wall of fluid.
The slides also mention a very specific vital sign anomaly, pulsus paradoxus.
This is an abnormally large drop in systolic blood pressure. Specifically, a drop of more than 10 millimeters of mercury every time the patient takes a breath in. What causes that?
It is a fascinating physiological quirk. When you inhale, the pressure in your chest cavity drops, which naturally pulls more venous blood into the right side of the heart.
Normally, the right ventricle expands outward to accommodate this extra blood, but in tamponade, the right ventricle is trapped by the fluid sac. It cannot expand outward.
So as the extra blood rushes in, the right ventricle bulges inward, pushing the intraventricular septum directly into the left ventricle.
This completely squashes the left ventricle, drastically reducing its filling capacity, which causes that sudden, terrifying drop in systemic blood pressure during inspiration.
The diagnosis is confirmed instantly with a bedside echocardiogram, which will show the heart furiously swinging back and forth inside a massive fluid sac.
Management has to be immediate. The standard emergency procedure is pericardiocentesis. A large needle is inserted directly through the chest wall, guided by ultrasound, to puncture the pericardial sac and aspirate the fluid.
The moment the fluid is pulled out, the pressure drops, the heart expands, and the patient's blood pressure rebounds instantly. It is miraculous to watch.
However, it carries the massive risk of the needle accidentally lacerating a coronary artery or puncturing the heart muscle itself.
If the effusions keep returning, the surgeons will perform a pericardiotomy, cutting a window in the pericardial sac to allow the fluid to continuously drain into the surrounding tissues.
Finally, we reach the ultimate endpoint, the worst-case scenario, cardiac arrest.
This is the complete sudden cessation of cardiac mechanical activity. The heart stops pumping blood entirely.
The causes are usually lethal arrhythmias triggered by the failing ischemic muscle, ventricular fibrillation, where the ventricles just twitch chaotically, or a systole, a complete flatline.
It can also manifest as pulseless electrical activity, or PEA. In PEA, the electrical system on the monitor looks somewhat normal, but the heart muscle is too damaged, or there is a massive obstruction, like a PE or tamponade, preventing any physical contraction.
The clinical presentation of arrest is unmistakable. Sudden loss of consciousness, absent palpable pulses. Blood pressure becomes unmeasurable.
Breathing stops completely, or you see horrifying, ineffective agonal gasps. The skin turns pallid and cyanotic.
Without intervention, irreversible anoxic brain damage begins within minutes, which means we are thrust instantly into the chaos and precision of ACLS advanced cardiovascular life support.
The first, most vital step in ACLS is rapid recognition. Do not waste time hunting for a pulse for more than 10 seconds.
If they are unresponsive and not breathing normally, activate the emergency response system. Call the code.
The absolute, undeniable foundation of survival is high-quality CPR. Everything else is secondary.
You must manually compress the chest hard and fast at a rate of 100 to 120 compressions per minute, allowing for full chest recoil.
You are physically taking over the job of the heart, squeezing it between the sternum and the spine to force a tiny fraction of normal blood flow to the brain.
While compressions are ongoing, a second rescuer manages the airway, utilizing a bag valve mask connected to 100% oxygen to force air into the lungs.
As soon as the crash cart and the defibrillator arrive, you pause compressions for no more than a few seconds to analyze the underlying electrical rhythm.
If the monitor shows a shockable rhythm, which is strictly defined as ventricular fibrillation or pulseless ventricular tachycardia, immediate defibrillation is the priority.
The goal is to deliver that first shock within 2 minutes of the arrest.
Defibrillation doesn't restart the heart. It stops it completely. The massive electrical shock simultaneously depolarizes every single cell in the myocardium.
It wipes the chaotic electrical slate clean, praying that the heart's natural pacemaker, the SA node, will wake up and resume a coordinated, normal rhythm.
After the shock is delivered, you do not pause to look at the monitor or feel for a pulse. You instantly slam your hands back on the chest and resume compressions for 2 solid minutes.
While high-quality CPR and defibrillation are cycling, the team is establishing an advanced airway, like an endotracheal tube, ensuring perfect continuous ventilation without having to pause compressions.
And then we turn to the pharmacology. We crack open the crash cart. The primary drug in any cardiac arrest algorithm is epinephrine.
We mentioned it's a vasopressor, but what is it actually doing at the receptor level during a code?
Epinephrine is synthetic adrenaline. It binds aggressively to the alpha-1 adrenergic receptors in the peripheral blood vessels, causing massive, profound vasoconstriction.
It clamps down all the blood vessels in the arms, legs, and gut. Why? Because during CPR, you are barely generating enough pressure to circulate blood.
By clamping down the periphery, epinephrine shunts whatever meager blood volume you are moving directly to the central core.
To the coronary arteries to feed the heart, and the carotid arteries to feed the brain. It also binds to beta-1 receptors in the heart to increase the automaticity and contractility, trying to kickstart the muscle.
The standard dose is 1 milligram, given every 3 to 5 minutes via rapid 5e push.
But it's critical to remember that because there is no normal cardiac output to circulate the drug, the nurse must immediately follow the epinephrine push with a rapid 20 milliliter saline flush and physically elevate the patient's arm for 10 to 20 seconds.
This uses gravity and fluid dynamics to manually force the drug out of the peripheral IV and into the central circulation where it can work.
If the patient remains in profound shock with unmeasurable blood pressures, even after a pulse returns, we might escalate to continuous intravenous infusions of potent vasopressors like norepinephrine or dopamine,
Which must be administered through a central line to prevent severe tissue necrosis if the IV infiltrates.
If the patient is suffering from symptomatic bradycardia, where the heart rate is so profoundly slow that they are losing consciousness and their blood pressure is crashing, the drug of choice is atropine.
Atropine works by blocking the parasympathetic nervous system, specifically the vagus nerve, which acts as the brakes on the heart. By taking the brakes off, it allows the SA node to fire faster.
The dose is 0.5 milligrams IV push, repeatable up to a maximum of 3 milligrams. Now, what if the patient is in VFib or pulseless VTach? We have shocked them multiple times, we've given epinephrine, and the chaotic rhythm just will not break.
That is when we deploy our primary antiarrhythmic, amiodarone.
Amiodarone is a complex drug that acts on the potassium, sodium, and calcium channels of the cardiac cells. It vastly prolongs the action potential and the refractory period.
Meaning it forces the wildly misfiring cells to pause and reset, helping to stabilize the electrical chaos. The initial dose in a pulseless arrest is an IV push of 300 milligrams, potentially followed by a second dose of 150 milligrams if the lethal rhythm persists.
The slides also mention sodium bicarbonate and magnesium sulfate.
Sodium bicarbonate is used to correct severe metabolic acidosis because when tissues are starved of oxygen, they produce massive amounts of lactic acid. A highly acidic blood pH prevents epinephrine from binding to receptors.
But it is not given routinely anymore. It is driven by arterial blood gas results. Magnesium sulfate is a niche drug used specifically for a unique twisted ribbon type of ventricular tachycardia called torsades de pointes,
Which is often triggered by critically low magnesium levels. Magnesium stabilizes the cellular membrane and the sodium-potassium pump.
Let's assume the team performs flawlessly. High-quality CPR, rapid defibrillation, precise pharmacology. Suddenly you feel a strong carotid pulse. The blood pressure monitor registers 110/70.
You have achieved ROSC return of spontaneous circulation. The instinct is to celebrate, but the most dangerous phase is just beginning. Post-resuscitation care is an incredibly complex high-wire act.
The brain has been starved of oxygen for an unknown number of minutes. The heart has been pummeled and shocked. What are the immediate priorities?
First, you obtain a STAT-12 lead ECG. You need to know if a massive ST segment elevation myocardial infarction, a STEMI, caused the arrest.
If it did, the patient goes directly from the floor to the cardiac catheterization lab to open the blocked artery. You ensure continuous hemodynamic monitoring.
But crucially, if the patient achieves ROSC but remains comatose and unresponsive, you must initiate targeted temperature management, or TTM.
TTM, or therapeutic hypothermia. The critical care team uses cooling blankets, ice packs, or specialized intravascular cooling catheters to deliberately, carefully drop the patient's core body temperature down to between 32 and 36 degrees Celsius and maintain it there for at least 24 hours.
This seems brutal. Why are we freezing a patient who just survived an arrest?
Because of reperfusion injury. When blood flow stops, brain cells become incredibly fragile. When circulation is suddenly restored, the massive rush of oxygen and immune cells causes an explosive, devastating inflammatory cascade that can destroy whatever brain tissues survived the initial arrest.
By inducing hypothermia, we drastically slow down the cerebral metabolic rate. The brain cells require significantly less oxygen, and the inflammatory cascade is blunted. It is neuroprotective.
The absolute worst thing you can allow to happen is for the comatose patient to develop a fever. Hyperthermia massively increases the brain's oxygen demand and guarantees severe, irreversible neurological devastation.
That journey from a simple assessment of crackles at 0900 all the way to targeted temperature management in the ICU perfectly illustrates the terrifying speed and complexity of heart failure. Now, we have to bring this all together.
We have to prove that we understand the clinical judgment required. It is time for solving the NCLEX case. The reveal.
Let's go all the way back to our patient at 1200. Let's look at the bedside realities. The patient with the crackles, the dropping 88% oxygen, the massive edema, the skyrocketing 920 BNP, and the new provider orders for furosemide, oxygen, and fluid restriction.
We need to tackle the matrix challenge from slide 34. Let's argue through this. We will select the priority nursing interventions and fiercely justify why the distractors are not just wrong, but physiologically dangerous.
Let's begin with System 1, the respiratory system. The four options presented were: monitor oxygen saturation continuously, position the client flat to improve oxygenation, encourage frequent coughing and deep breathing, administer bronchodilators Q4Hers.
The correct interventions are absolutely to monitor oxygen saturation continuously and to encourage frequent coughing and deep breathing.
We must monitor O2 continuously because their levels are actively dropping from 91% to 88%. We have to know immediately if the 2 liters of nasal cannula oxygen is actually working or if we need to escalate to a non-rebreather mask.
Coughing and deep breathing, or using an incentive spirometer, physically forces the airways to stay open and helps mobilize the fluid that is leaking into the alveolar spaces, optimizing whatever surface area is left for gas exchange.
Now let's analyze the distractors. Positioning the client flat to improve oxygenation is a lethal trap. We discussed the physics of this.
If you lay this severely fluid-overloaded patient flat, gravity will pull the massive volume of fluid from their swollen legs and engorged abdomen directly back into the central venous return.
This will immediately overwhelm the failing right ventricle, flood the pulmonary bed, and drown the patient. They must remain in high Fowler's upright position.
Administering bronchodilators. That is completely outside the nursing scope of practice because there's no provider order for it in our scenario. Furthermore, the root cause of the crackles is fluid, not airway bronchospasm. Albuterol won't dry out a wet lung.
Spot on. Let's move to System 2, the cardiovascular system. The 4 options. Encourage a high-sodium diet to prevent hypotension. Assess daily weights for fluid retention. Limit physical activity to promote bed rest-induced recovery. Monitor for signs of jugular venous distension.
The essential, correct nursing actions are assessing daily weights and monitoring for JVD.
We established that daily weights are the absolute gold standard for tracking fluid status. We just pushed 40 milligrams of 5E furosemide. Tomorrow morning's weight is the definitive test of whether that drug worked.
Monitoring for JVD gives us a real-time physical gauge of the pressure backing up from the failing right ventricle. If the JVD decreases over the next few hours, we know the diuresis is successfully offloading the venous system.
The distractors here are terrifying. Encouraging a high-sodium diet to prevent hypotension, that is physiological sabotage.
While diuresis lowers blood pressure, giving a heart failure patient sodium acts as a sponge, aggressively pulling massive amounts of water back into the vascular space. It will instantly worsen the volume overload and accelerate the pulmonary edema. The goal is strict sodium restriction.
And limiting physical activity to promote strict bed rest. We already dismantled this outdated practice. Prolonged bed rest causes massive deconditioning and guarantees the formation of DVTs. The intervention should be alternating scheduled rest with progressive, monitored activity.
Perfect. System 3, the urinary system. The options. Encourage increased fluid intake to avoid dehydration. Implement routine bladder scans to detect retention. Assess for signs of oliguria. Monitor urine output hourly.
The correct choices are implementing bladder scans, assessing for oliguria, and strict hourly monitoring of urine output. We just administered a massive dose of a loop diuretic. We expect the kidneys to open the floodgates.
Monitoring output hourly is the only way to ensure the medication is functioning. If the urinary catheter is empty an hour after pushing furosemide, we have a major problem.
They might be developing oliguria, dangerously low urine output, which perfectly aligns with their climbing BUN and creatinine, indicating the kidneys are shutting down from lack of perfusion.
If they're urinating on their own but their output seems low, a quick, non-invasive bladder scan ensures the urine isn't just backing up in the bladder due to a structural obstruction, but rather that the kidneys actually failed to produce it.
The distractor here, encouraging increased fluid intake to avoid dehydration, is dangerously wrong. It represents a total failure to understand the patient's current clinical state.
The patient is profoundly fluid overloaded, indicated by the 2+ pitting edema, the crackles, and the soaring BNP. Telling them to drink more water is pouring gasoline on a fire.
Moreover, we have a specific hard provider order restricting oral fluids to 1,500 milliliters. Telling them to force fluids is a direct harmful violation of the medical plan of care.
Finally, System 4, the digestive system. The options: monitor for abdominal swelling or ascites, assess for anorexia and provide dietary support, provide an antacid to manage gastric distress, encourage a diet high in fats for caloric intake.
The correct nursing interventions are monitoring for abdominal swelling or ascites and actively assessing for anorexia to provide support.
As we discussed in the pathophysiology section, right-sided heart failure causes massive venous congestion. The portal vein backs up, engorging the liver and the entire gastrointestinal tract. This fluid leaks into the abdomen, causing ascites.
A gut swollen with venous fluid cannot digest properly, leading directly to profound nausea and anorexia, which explains why our patient reported decreased oral intake over the last 24 hours. The nurse must recognize this systemic symptom and advocate for small, frequent, highly tolerable meals.
Why are the others incorrect? Providing an antacid might seem helpful for nausea, but it is administering a medication without a provider order, completely outside the scope of nursing practice. Furthermore, the nausea is caused by vascular engorgement, not excessive stomach acid.
Encouraging a diet high in fats for caloric intake. That is a catastrophic misunderstanding of cardiovascular health. A high-fat diet completely contradicts the essential heart-healthy, low-cholesterol, guideline-directed medical therapy lifestyle modifications required to stop the progression of coronary artery disease, which is likely what caused the heart failure in the first place.
Looking back, it is a staggering amount of highly technical, interconnected information to synthesize. But breaking it down chronologically through a patient scenario proves that none of these facts exist in a vacuum. Everything, the heart, the lungs, the kidneys, the medications, is intimately connected.
It really is incredible. We covered massive ground today. We took a crashing patient at 1200, unpacked the complex hemodynamics separating right-sided venous congestion from left-sided pulmonary edema, decoded the cardiorenal connection of the lab values, deployed an intricate pharmacological arsenal of diuretics and neurohormonal blockers, established the critical bedside nursing interventions, braced for the terrifying reality of tamponade and cardiogenic shock, and executed the life-saving protocols of ECLS.
Before we close out this session, I want to leave you with a final clinical reflection to carry into your next rotation. Consider how the body's major organ systems, the heart, the lungs, the kidneys, are locked in a constant, desperate, delicate conversation. When the heart muscle fails, the kidneys panic from the lack of perfusion and actively hold on to fluid, which in turn violently drowns the delicate tissue of the lungs. As a nurse, you are never just treating a cardiac issue. You're acting as the ultimate interpreter for a system-wide distress signal. How will you refine your physical assessment skills, your critical thinking, to catch that very first subtle whisper of a failing system? The slight jump in heart rate, the single crackle at the lung base, long before the catastrophic alarm bells of a code blue start ringing.
Catching the whisper before the alarm. That is the true art and science of nursing. Keep that vivid reality in mind the next time you place your stethoscope on a patient's chest. Thank you for enduring this intense, comprehensive deep dive. Keep pushing through the exhaustion, keep studying the why behind the symptoms, and keep fiercely advocating for the patients relying on your judgment. We believe in your potential, and we will catch you on the next deep dive.